Thanks very much, and thanks for the opportunity to talk about the Advanced Health Research and Translation Centres. And I just emphasise that although we have on a number of occasions already got together the centres that are running in Australia, this is a personal view, it's not an accumulative view. But I do believe that this is a unique opportunity for the MRFF to utilise the centres to achieve the goals that Ian just pointed out. And also for those who weren't in the room yesterday, we had a wonderful presentation from Sir John Took about the processes that have occurred in the UK, and I'll refer to that. But again, I think that has provided us up with a bit of a template for success in Australia. So if we go right back to what communities want, I think we all agree communities want better, more accessible, equitable and affordable health. I think there's sort of no debate about that. But we don't have that. To achieve that, we have to reform the system. And reforming the system is very dependent on the ability of the system to rapidly move innovation and research and workforce development and workforce change into healthcare. And unfortunately, we know that we're really pretty bad at that. And again, yesterday we had a great presentation about breast cancer, identifying that some of the great ideas in breast cancer have taken 17 years to go from, relatively mature ideas into a position where most people are utilising those ideas. So we're really bad at it. And why are we bad at it? Well, firstly, we don't invest in the translational process, and obviously the MRFF hopefully is part of that. We also know that the KPIs are often wrong. So the KPIs for our partners, that is the health system, us being academia, researchers and the research sector, the KPIs are often transactional. So they're about how many operations you do, how many hours you spend in the emergency department, those sorts, how much money you either make or save. And those KPIs are not outcome KPIs, and they don't encourage the CEOs of our hospitals and our primary care providers to engage in research, because there's no KPI-driven process to enable that. We often have entrenched practice in all of our clinical practice. We like to do what we've always done, even though it may not be the right thing to do. We're all time poor, and that then doesn't allow us to change. There are no financial incentives to change. In fact, there are financial incentives not to change. If we're doing too many arthroscopies, there's actually lots of financial incentives to keep on doing too many arthroscopies. And as we all know, both at a population level, but also at a service delivery level, behavioural change is incredibly difficult. And it is one of the research spaces which we're not that good at, understanding how to change behaviour. So this slide just identifies some of those issues in a little bit more detail. We also have a problem in Australia of the dichotomy of funding streams. So we have money coming from the federal government primarily into primary care, and state money going into tertiary care. That causes a whole lot of unintended consequences of cost shifting, and again, not necessarily understanding that money spent, for instance, on prevention will actually save money at the tertiary level, but the prevention money seems to have to come from the federal rather from the state level. So those dichotomies are difficult. As I mentioned, there's dichotomies of KPIs, and our health funding is very much based on transactions and outputs rather than outcomes, rather than saying, how do we reduce, as I'll talk about, how do we reduce the number of people with colon cancer rather than how do we actually increase the number of colectomies, etc., that we're doing. The outcome of that is that high impact bioscience and IT is not linked to healthcare innovation. We have very poor linkages between our undergraduate workforce training and our postgraduate training, and I think the colleges are an important part of that. And evaluation of healthcare delivery does not utilise the research sector at all, really. And again, I emphasise the poor links between primary and tertiary care. And what's happened? I think what's happened is we've lost a whole lot of healthcare improvement opportunities. And if we just concentrate at the tertiary level, I think our teaching hospitals have fallen behind their international competitors. So the concept of academic health science centres or advanced health translation centres has been around for some time, and Sir John spoke about those yesterday, but primarily what they do is link research, teaching and clinical care. Makes amazing sense, but actually it's very difficult to do. But if you look around the world, the best are the ones that have the best governance, high level excellence, are big, size is important, and are absolutely integrated with healthcare delivery. So just to put up a couple of international models, Johns Hopkins obviously is one of the classic American academic health science centres. Very clear links between the faculty and the health system, all run and governed by a single integrated governance. I guess over the last few years we've been looking more at the UK models. Their health system's a little more the same as ours, and a very big example would be the Manchester Academic Health Science Centre, system-wide, right across Manchester. But the one we heard about yesterday, and I think the one that probably most of us have modelled ours on, has been UCL Partners, now probably the biggest aggregation of health research and healthcare delivery in Europe, and one based on a partnership model, not necessarily totally integrated governance, but partnerships between healthcare delivery, between research and workforce development. So the McKeon review was just mentioned, and this comes out of the McKeon review. And one of the recommendations of the McKeon review was the establishment of integrated health research centres. Establish and fund integrated research centres that combine hospital, community care, universities, and MRIs into an integrated centre. And establish clear sets of criteria and initially select 4 to 8 and provide funding of up to $10 million per annum. So I thought that was a really good recommendation of the McKeon review. It's not what I'm necessarily going to argue for today, but it just goes to show that a fabulous review that looked very carefully at health and medical research across Australia recognised the need for that integration between health and research. And obviously, really importantly, evaluate the performance. If you are going to give money, you need to have evaluation. So as you know, now actually 6 years ago, the Warwick Anderson and the AAHMS put out a discussion paper on developing advanced health research centres in Australia, and that ultimately led to an accreditation round, and 12 submissions were put up from around the country. 8 were invited for interview, and 4 were officially recognised and are listed there. And I think very pleased that the NHMRC has now announced a further round for submissions by the end of this year, and that will include a special submissions for regional centres. And so hopefully at the end of that process, we'll have a national spread of academic health science centres or advanced health research and translation centres across the country, linking health and research, workforce, clinical delivery and research together right across the country. And we've already developed some plans to have a national alliance of our academic health science centres across the country, and a number of us are already members of the International Alliance. So I think that process is going very well. And I just wanted to highlight a little bit by using the South Australian example, but also taking some of the examples from the other groups, the strengths of the AHRTCs. And firstly, size. I think they have the capacity to deliver a translational outcome across a very large geographical area, whether that's half of Sydney, or whether it's half of Melbourne, or the entire state of South Australia with or without electricity. They really have a capacity to do something at scale. They have all involved, obviously, the universities, the local hospital networks, or our major tertiary care providers, involving primary care. They can bring in Aboriginal health and rural activities. The most important thing, I think, is the strong engagement with health, and I'll talk about that in a minute. Bring in consumer engagement. I think they must be engaged in health reform. They must be looking at reforming the health system. But importantly, and this is where the universities and the MRIs come and join the health delivery system, is that they're underpinned by discovery science, they're underpinned by data science, and underpinned by implementation science. This is, don't look at it too carefully, but this is the governance of the South Australian one. I want to just make 2 points about two of the key groups. One is the executive group at the top, and that's co-chaired by myself as the director of the AHRTC and the Deputy Director of Health for the entire South Australian health system. So we have Jenny Richter, now Len, as that person at the top of the AHRTC, but also at the senior level of management for the whole of health in South Australia. And then we have our Translational Health Committee, and our Chief Health Officer, Paddy Phillips, who's also our Chief Public Health Officer, chairs the Translation Committee. So just as an example at the governance level of the integration between health and research, and those groups define the strategies and strategic priorities for the AHRTC, work together with the deans of the medical schools, work together with the CEOs of the hospitals, which are all on those committees, to define those priorities and then act on those priorities. I just thought I'd highlight what the AHRTCs can do just by using some of the examples from ours, but there are similar examples from the two Melbourne ones and the Sydney one. We set priorities around Aboriginal health, and the AHRTC actually wrote the plan for cardiac and cancer services for Aboriginal communities in South Australia. They wrote the plan for diabetes, the diabetes plan for South Australia, and are now developing plans around prisoner health. We identified that if all of the knowledge we know about bowel cancer was implemented, and we modelled this in South Australia across the 1.5 million people in South Australia, we could reduce colon cancer incidence by 80%. Colon cancer deaths by 80%. So that we have set out on a project to implement known knowledge in the area of bowel cancer in terms of, right from the start, in terms of things that prevent colon cancer, screening for colon cancer, optimal colonoscopy, optimal surgical management, etc. So that's something that can be delivered across a large geographic area such as South Australia, and one where we're implementing knowledge that we actually already have. We know in South Australia that only 30% of people who have an infarct have cardiac rehab. And so again, we can look at what happens if we increase that to 80%. And we can also ask the question, does that improve outcome? Because we actually don't know that. We can look at things. We know, for instance, that South Australia has the highest rate of arthroscopies in the country. Why is that? How do we get that back to a level consistent with evidence? Same applies around hysterectomies, caesarean sections, diabetic amputations, and so on. We can ensure that evidence-based pathways are looked at carefully and audited across the state. And then importantly, across the state, and I know we're all struggling with this across the country, how do we make sure that we have clinical trials working as efficiently and as well as possible? We don't currently actually measure how many clinical trials are happening in our hospitals. It's not a KPI for our CEOs. The delivery of clinical trial activity, the time from design to ethics to governance is not measured. So there's a whole lot of stuff that the AHRTC can do right across South Australia in terms of ensuring that those clinical trials are happening, that we're driving them with KPIs, and because we know that the more clinical trials we deliver, the better healthcare. And the same applies to commercialisation. How do we facilitate that process right across the board? And then how do we utilise the health system to make the commercialisation process even more effective in terms of test beds and other things? And data access and delivery, again, something that we're all aware of as being a problem, but a powerful tool across the country. And as e-records come to the fore, those e-records are going to be just so powerful and so important. And again, that intersection between the researchers within the MRIs and the universities and the healthcare system is going to be essential. And I believe the AHRTCs are there to provide that. I think there's a competitive component to this. We have to look across the world at the hubs and academic health centres that are being developed right across the world. This is very clearly an international trend which has been going on for 20 odd years, but one which we can't allow ourselves to be left behind. So a really important area. So I think the opportunity to embed evaluation, research and workforce development into the health services is a really important opportunity. I think we can develop a unique Australian model, MRIs, health, universities, consumers as a partnership, and the consequence will be to improve health and to create wealth, and clearly if it's supported by the MRFF, it's even more likely to happen. So what can the MRFF do? Well, I think the first is identify the AHRTCs as an ideal model partnership to accelerate translation of knowledge into healthcare. So I mentioned a number of the things that are on the slide. I won't go through it. New knowledge, over and underutilisation, and so on. So the identification by the MRFF as the AHRTCs being a model will help to drive behaviour, and I think that's very important. Secondly, we all know that funding drives behaviour, and I think we've had really good buy-in from our health partners, but funding will drive that even more. So that the health partners, all of our health partners, are short of money. They are looking at their budgets much more than they're looking at outcomes. And funding from an organisation like the MRFF will drive CEO behaviour and will drive behaviour below the CEOs at the statewide level, at the hospital level, at the primary care level. And I think that's really important. And I think that funding will drive our health services to embrace research and training. It will drive access to data, and it will drive clinical trial activity. In terms of the funding support, I would argue that and we heard yesterday that both the English system and the Australian system had accreditation without funding, and certainly that's been successful, and that has already resulted in really good partnerships. But I think those partnerships, to be sustainable, need infrastructure support, and I think the MRFF can look at that. I think project-based support for activities within the AHRTCs that fit with the priorities of the MRFF, I think they're absolutely the ideal vehicle to deliver that. And as I mentioned, obviously that needs evaluation and KPIs to ensure that that's delivered. And I think one of the key issues that we're all absolutely aware of is the loss of the clinician scientist, the loss of the medical graduate doing research, the loss of the dietitian doing research, the loss of the speech pathologist doing research. I think we've lost a lot of those people. We need to regain that career process, and people support through the MRFF within the context of the AHRTCs, within the context of healthcare delivery, through either increased practitioner-like fellowships, clinician scientist pathways, and so on, would be critically important. So I just go back to what I said at the beginning. I think the MRFF can support the AHRTCs to utilise what I see as the critical partnership between research and health to more rapidly identify, develop and introduce innovation and workforce change. And I think it's a really important point that if we're changing the healthcare system, then the workforce has to change as well. But if we can more rapidly, over a shorter period of time than the 17 years that it takes that we heard about yesterday in terms of breast cancer, if we can do that rapidly in the context of small numbers of years rather than decades, introduce the innovation that we have, introduce the research outcomes that we have and the workforce change into the healthcare system, I think the MRFF will have spent its money wisely. So thank you very much.